Good afternoon. Thank you very much for having me here today. It's a great honor to be here with you all via this online recording system. I want to especially thank Dr. Irfan and whole JSMU team, Principal Sindh Medical College, and whole audiovisual team. I would like to discuss a very serious healthcare crisis which is being experienced by all over the globe, which is none other than COVID-19 virus. As a frontline member of NHS, I would like to share my experience with you all. But before we start, let me introduce myself. I am Dr. Faisal Ozair, consultant diabetes endocrinologist at William Harvey Hospital, East Kent, which is the main referral center for this region. In the next half an hour or so, I would like to discuss this pandemic and its link with the diabetes. So let me start. Start with some background. As in our professional life, we have not witnessed any healthcare crisis of this magnitude and severity before. COVID-19 is caused by SARS-CoV-2 virus and is labeled pandemic by WHO, and it's sweeping all around the globe. So far, the total number of cases reported more than 3 million, and 200,000 deaths have been reported in all over the world. And unfortunately, these numbers will rise substantially in the forthcoming weeks and months. Since diabetes poses a great risk to the severity of the illness, healthcare providers need to be more vigilant in the assessment of such patients who present with these symptoms like shortness of breath or fever. And as we all know, poor glycemic control is a risk factor for serious infection and adverse outcome. This is the classical example of pandemic, where you can see almost all of the world is affected by this virus, and North America and Europe are the worst hit. So what are the objectives of the talk today? So we will focus on two basic fundamental questions. We'll try to answer these. The question number one, are people with diabetes at increased risk of contracting COVID-19? And question number two, does diabetes increases the risk of COVID-19 severity? And in the end, I would like to discuss the management of COVID-19 patients with diabetes. I'll start with my clinical case, which was referred to me from intensive care unit. She is a 47-year-old lady, COVID positive, was in intensive care unit, was currently intubated and ventilated on NG tube feeding. She had history of type 2 diabetes and was on gliclazide and metformin. She was also running ectopid infusion for controlling her blood glucose, which is running quite high, around 10 units per hour. And even then, the blood sugar running around 180 to 270 milligram per deciliter. And whenever they try to cut down, its blood sugar climb up again. She had past medical history of hypertension, type 2 diabetes, with poor control. Last HbA1c was 8.3%. She also had osteoarthritis and degenerative spinal disease, fibromyalgia, chronic fatigue, and her BMI was 31. On initial assessment, she was full escalation. She had endotracheal tube in situ, intubated and ventilated. She was nursed in deep prone position with PEP of 7 and FiO2 of 30%. Fortunately, she was unsupported from cardiovascular point of view. She wasn't on inotropes. Heart rate was 104 and MAP was 87. Her GCS was 8. She was NG-fed and ectopid infusion. She had good renal function with urine out of around 60 mL per hour. Her blood gases showed pH of 7.31. PO2 was low. BICAR was low and BXS6 was minus 4.5, suggestive of metabolic acidosis with hypoxic. Ketones was raised 2.5 millimoles, which is equivalent to around 25 milligram per deciliter. Although she was type 2, so it's unlikely to have ketones of this level. She was started in meropenem, but she was keep on spiking, so switched to ceftriaxone by advice of microbiologist. Her blood cultures was negative, and so as Legionella and pneumococcal antigens were. However, her sputum grew E. coli, which was sensitive to antibiotics. This is her initial chest X-ray, and you can appreciate she had bilateral infiltrate on both the bases, but subsequent X-ray showed worsening of signs with dense consolidation on left side, and she was intubated, ventilated, central line, and angiosphere as well. Her virology report PCR confirmed she had SARS-CoV-2 positive with RNA detected. These were her initial blood results. On the x-axis is the dates, and on the y-axis are the levels. I'm really sorry, the units are different compared to Pakistan and US. But the green means good and the red means abnormal. So hemoglobin was good initially, but subsequently fall. Lymphocytes were quite low. I will tell you why the significance, why we check lymphocytes that frequently. And as you can appreciate, her lymphocytes gone down as little as 0.5. Fortunately, her kidney function remained well throughout the admission, but her CRP was quite high, peaked up to 363 and remains throughout high. Her ferritin was raised as well, and procalcitonin was quite raised, but subsequently it showed good improvement. Her D dimers were raised as well, so as troponin I. So I would like to discuss the laboratory features associated with worse outcome in COVID-19 patient. Lymphopenia, one of them, elevated liver enzymes, elevated LDH, elevated inflammatory markers including CRP, ferritin, and procalcitonin, raised D dimers, raised prothrombin time, elevated troponin, and acute kidney injury. So these are the markers of worse outcome with COVID-19 patients. So these are the comorbidities associated with severe illness and mortality in COVID-19 patient. And as you can see, diabetes is second on the list after cardiovascular disease. Others are hypertension, chronic lung disease, cancer, chronic kidney disease, and obesity, BMI of more than 30. This is the initial insight which we got from our NHS advisory board after seeing a couple of hundred patients, and these are their initial assessment. We saw lots of atypical ketosis in diabetic type 2 patients. Fluid replacement should be modified, especially keep in mind ARDS. In a subset of ventilated patient, we see lots of insulin resistance, with insulin requirement may go up to 20 units per hour to manage hyperglycemia. And significant risk of hypoglycemia were there because the patient was nursed in prone position. And once a patient with COVID-19 diabetes patient discharged on insulin need to be followed up to continue need of insulin was unclear at that time. So this is the guideline from Association of British Diabetologists. I'm sorry the slides are busy, which you can read in your convenient time, but let me just summarize it for you. COVID-19 patient with or without previously diagnosed diabetes are increased risk of emergency state of hyperglycemia with ketosis, diabetic ketoacidosis, and hyperosmolar coma. So the most important thing, you have to check your patient's blood sugar. If it is more than 12 millimoles or more than 250 milligram per deciliter on 2 different occasions, please check ketones, either serum or urine. Stop SGLT2 and metformin, and be careful about fluid prescription because of lung leak due to myocarditis and ARDS. This is the flow chart. How do you manage these patients? Initial assessment is necessary, as always with any other patient. Airway, breathing, circulation, and make sure you stop all the offending drugs, including SGLT2 and metformin if they are unwell, and check the glucose. If the glucose are high on two different equations, please check the ketones, and depends on if it is DKA or hyperosmolar hyperglycemic state, treat accordingly. These are just check what you have to check for ketones, and look for insulin, as well as look for the foot here as well, because we see a few patients with the foot involvement as well, despite having good circulation. So I searched the PubMed and different journals and come across two important studies which I would like to share. And these two studies coincidentally come from one from Italy and other from China, which were the first two countries affected by this virus. So this is the Italian study. Among around 1,300 patients, diabetes related to be the second most frequent comorbidities. And diabetic patient resulted to have significant risk of ICU admission. And around 470 patients analyzed for secondary outcome, diabetes resulted to be the second highest mortality risk factor. And this is the study from China. There's a big study of around 70,000 patients published in Chinese Center of Disease Control, which shows increased mortality in patients with diabetes, 2.3% overall compared to 7.3% with diabetes, which is quite significant. So the conclusion of these two studies were, according to the current available data, people with diabetes don't appear to be high risk for developing COVID-19, but if they contract, the emerging data suggest that having diabetes is a risk factor to develop poor outcomes. Just want to show you the position of patient nursed in ICU. This prone position, and you can see lots of tubes. Just imagine how difficult it is to care this patient. And if you read the history from China and Italy, usually they're 1-to-1 ratio for the nursing staff and the patient, but there they have to see 1:3, and on some occasion it's 1:6. So it is quite difficult. And if with the better sugar control, you may avoid some other tubes like DK protocol or HHS. That's why it's so important to have your blood sugar, your patient's blood sugar is well controlled. So why explain the increased risk for diabetics? So there are 2 or 3 hypotheses. So one, diabetic patient have impaired immune response to both cytokine profile and the immune response, including T cells and macrophages activation. And many patients with diabetes are obese, and obesity, all we know, is a risk factor for severe infection. And lastly, late diabetic complications such as diabetic kidney disease, ischemic heart disease may complicate the situation with diabetes, making it more fragile and further increasing the severity of COVID-19 disease. So what could be the generalized management strategy for these patients? For type 2, in many patients with type 2 diabetes, insulin treatment is preferred if they are unwell. However, if they're stable, maybe continue oral tablets. But for type 1 patients, insulin dose need to be titrated using frequent glucose and ketone monitoring to avoid hypoglycemia in patients with poor food intake, and adding correctional boluses of fast-acting insulin to avoid severe hyperglycemia and ketoacidosis. So the final conclusion is, if we take all together, patients with diabetes are at high risk and comparative group of patients treated for COVID-19. with an increased requirement of hospitalization. Patient with diabetes needs intensive attention to reduce risk of fatalities. And patient with diabetes should follow the general prevention advice given by the authorities thoroughly to avoid infection with COVID-19. My simple take-home message: don't underestimate the importance of this ketometer. This will give you lots of information if the patient, especially if the patient is unwell. So always check your patient's ketone, serum ketones prefer, if the blood sugar is high or to different indication. If you find it difficult to have ketometer, please use urine, and it will give you definitely good idea of where your patient is heading to. The darker the result, the more unwell the patient and may need hospitalization with IV insulin infusion. So these are my references for you to have a look. And many thanks for your attention. And please do ask me a question, email me on f.ozair@nhs.net, and I'm more than happy to answer any of your query. And in the end, I would just like to thank JSMU AANA, and this educational activity is sponsored by them. Many thanks.